Next one, please. So this is more of a, in the hospital, you know, I get called all the time. Oh, I had, you know, some lady came in with a urinary tract infection with bacteremia, and do I need to give her, you know, like an E. coli, she's been on row 7, do I need to give her 2 weeks of IV therapy? Can I switch her to oral? Can it be 1 week of treatment? And so this was a interesting retrospective study. They asked the question, they said, what's the optimal antimicrobial treatment duration for gram-negative bloodstream infection? It's sort of a general term, but this study was almost all looking at women who had pyelonephritis with bacteremia. Almost all of it was E. coli, which is the most common. And they wanted to look back, and they pulled up the charts and see how long people were treated for bacteremia. And it was a retrospective cohort study to try to match things, but the only difference being the length of antibiotic. And so they called it short course, which was 7 to 10 days of antibiotics, versus longer, greater than 10 days of antibiotic therapy for an uncomplicated gram-negative. So uncomplicated meaning like they didn't have like a perinephric abscess or they didn't get osteomyelitis. Just a lady comes in with pyelo and has bacteremia, and you know, should you put a PICC line in them for 2 weeks? Can you do orals, etc. And again, the majority of patients were women with E. coli bloodstream infections from a urinary tract infection. And the treatment, some people give IV therapy for the week or two. Some were given IV, then switched to highly bioavailable oral agents, which usually ones like Bactrim or the quinolones particularly. And what was interesting was that there was a significant increased risk of failure with short course therapy, which averaged about 8 days, compared to longer therapy, which was about 13 to 14 days. So I was a little bit surprised, and you know, I've always sort of wishy-washy 7 to 14 days. I don't know until they're better, but the risk of relapse was 2.5 times greater in people treated with short course versus long course therapy. So the conclusion, at least of this cohort study, was that the common clinical practice of 2 weeks of antimicrobial therapy should be given uncomplicated gram-negative bloodstream infection. But important, if you have oral treatment options, particularly Bactrim or the quinolones, you can switch these patients over to that. So the 14 days of treatment you're going to give doesn't have to be all in the hospital. And usually, you know, 2 to 3 days, they're afavorable, they're doing well, you got the susceptibilities out, and then, you know, they have no reason to keep them in the hospital. You can then switch them to oral therapy to complete their treatment. But it's good to know that 2 weeks is the standard. You know, the only time that we really need IV therapy for the whole length of therapy of bacteremia is Staph aureus. Okay, so don't ever switch somebody to like a Keflex or something like that, because that's the one absolute indication for bacteremia is Staph aureus. But otherwise, if you have an oral option, you can usually successfully switch these patients to therapy for 2 weeks.
So are you going to, on those that are resistant to Bactrim and Cipro, send them to an infusion center?
I think you'd have to.
So you wouldn't do an oral beta-lactam, like, I don't know.
I suppose you could do amoxicillin, gram to your idea, but it's not going to be sensitive. Yeah, it's not going to be sensitive because it'll be resistant to everything. Yeah.
And if you do the 3rd generation cephalosporin, you know that they only get levels of 3
but
or 4.
See, but we do that relatively. I mean, we'll do 7 days of IV, and then like
cephalosporins.
Yeah, I know the limitations, but it's, I don't know.
We don't know.
Do you know how they measured relapse?
I would have to check.
I just want to make sure it's not like retesting urine culture, like a urine culture.
Good.
Just that would be the only thing I would make sure.
Also, this next one is, you know, if you've listened to my talks over the years, I've beaten my head against the wall how important it is just to treat urinary tract infections. Go on the basis of symptoms. You know, we don't. Actually, my next slide is going to show this. Actually, we'll do this first. We'll go back to this. Okay, next slide. Go to the next slide first. What is the best way to diagnose uncomplicated urinary tract infection, which is cystitis, okay? And the answer is ask the patient, do you feel like you have a bladder infection? That's all you got to do, okay? And this is just to review, and this study I'm going to bring up actually confirms exactly what this says. So Thomas Hooton, who's from the University of Washington, he's like the expert urologist. In 2012, New England Journal said, don't do a dipstick, urinalysis, or culture, because these can be negative or misleading. Just treat on the basis of classic symptoms and uncomplicated urinary tract. Say, what are your symptoms? I got dysuria frequency, I have no discharge or irritation. And we've been saying 95% of the chance that that person who has, a woman who has those symptoms has cystitis. And they can do the cystitis. They've done studies where even when the culture is negative, they put catheters into women's bladder and got out E. coli. And so you say, okay, that's pretty good, but why don't we do culture? So 95% of the time, it's 97% it's sensitive for picking up bladder infections. If you look at other things that a lot of people do, is one is the dipstick, okay? They look at leukocyte esterase and or nitrate. This is 75% sensitive. So again, symptoms are more important for diagnosis, even if the dip is negative. And then everybody thinks the gold standard is the culture. Greater than 100,000 bacterial CFUs has been the traditional criterion for UTI, but the bottom line is it misses up to about half the cases. And so keep these numbers in mind. So let me flip back to this other study. So this is called Women with Symptoms of a UTI but a negative urine culture using a PCR-based quantification of E. coli suggests infection in most cases. So they say that 20 to 30% of women with symptoms of UTI have negative cultures. Okay, I've seen as high as 50%. So women come into your office, they complain of dysuria frequency. You do a culture on them, and you say that's the gold standard, and you call them 3 days later, say your culture is negative. So about 25 to 30% of women who have symptoms of the UTI have negative cultures. So this study wanted to say, what do those women who have negative cultures really have? So what they did was they took 220 women who had typical urinary tract infections, and they looked at also 86 women that had no symptoms at all. And they did the cultures, and they did a PCR test to look for E. coli and Staph cephalophthicus, which are the most common causes of bladder infection in women. So in the symptomatic group, 80% had positive cultures, okay, which goes with what they say, 20-30% of women symptoms UTI have. But 20% had negative cultures. But when they looked at a PCR, they found 96% of these patients with positive and negative cultures had E. coli in their urine. So the symptoms was 96%, the symptoms of a UTI was 96% sensitive in picking up a urinary tract infection. But you say, hey, maybe this is E. coli that was just there, wasn't the cause. So then they looked at the placebo, not placebo, but the asymptomatic group. So 11% of this asymptomatic group had asymptomatic bacteria. They had positive cultures for E. coli. And those 11 plus 1% more were PCR positive. Okay, so this tells you that asymptomatic groups, they can have some E. coli, but a lot of them, the rest of them do not have E. coli as a normal, their DNA in their urine. The patients had symptoms, 96% of these patients had E. coli PCR positive. So their conclusion was that almost all women with typical urinary complaints and a negative culture still have infection with E. coli, okay? So that is, the bottom line is go for the symptoms, okay? And they've looked at other studies I presented previously where women will have group B strep in the urine, they'll have enterococcus, and the doctor gets them and they'll treat them for this. But when they actually do like a straight cath from these women, they find E. coli. So cultures, one, are not good for two reasons. One, because they're going to miss about a quarter of women who have bladder infections. And two, oftentimes they're misleading because they're contaminated. They get eaten. They'll have enterococcus, group B strep, or things like that, which don't cause bladder infections. So 96% of the time, your urine, patient's dysuria symptoms, the UTI symptoms are the best thing. Skip the urine dipstick, skip the urine culture. The only time you should culture is if you treat these patients, the symptoms don't clear up, and then there may be a resistant bacteria. But again, and the best antibiotic to use, if you can do it, is macrodantin. Macrodantin in Washoe County covers 90% of E. coli, 95%, and Bactrim covers about 80 to 85%. And considering the fact that half the infections will clear up without even antibiotics, you're almost always going to clear up with what antibiotic you use. You should not do cultures. You should not do follow-up cultures unless the patient has symptoms. And again, we don't talk about it here, but the reason we treat people with urinary tract infections is not to prevent pyelonephritis. People with pyelonephritis present with pyelonephritis. They don't present with a UTI which you misdiagnosed or didn't treat properly. Okay, so women come in with pyelo, the back pain, the vomiting. They don't come in with urinary tract infection, and then a few days later you get the pyelo. So The only reason we're treating urinary tract infections is to resolve ladies' symptoms, which is obviously very important, okay? And so don't do urine cultures, don't do follow-up urine cultures unless they don't respond. The only time you do urine cultures, if they do come with pile, then it's very important.
You know, those negative cultures, you know, normally they talk about 100,000
Right.
colony-forming units, but women can have symptoms with 100,
Right.
just 100 colony-forming units.
And that's because they do 1/1000th of a drop of urine. So one colony is 1,000 E. coli, and women can have symptoms of just 1 to 200 colonies in their urine. So the urine culture is not very sensitive at all. It will pick up 100,000, but it's not going to pick up the small ones. And then you may just blow it off, or the microlab say only just a few colonies.
Yeah.
So go with the symptoms. All right, so that was a good article. Very helpful. So listen to the patient when all else fails. All right, if they feel like they got a bladder infection, you treat them. Okay. And this was a just for a little entertainment. I presented this a few months ago. This was an outbreak of Salmonella Typhimurium associated with playground sand in a preschool setting. This was in Spain, and they had 24 kids at this school develop Salmonella gastroenteritis, and the Salmonella was this one that's only been seen in birds, and so they had no evidence. There's no animals at the thing. The facilities was clean. The food was not infected. The water bowl was infected. And after this ongoing epidemic, they finally realized it was birds that were pooping into the sand lot. And so they closed the sand lot. They got rid of the epidemic. So I presented that a few months ago. So I thought another fun one in that same field if you have kids. This just came out about a week or two ago. It was called Toxic Bacteria Often Lurk in Playground Sandboxes. And they said past studies have shown public sandboxes can host pathogenic parasites, bacteria, and salmonella. And so they had 40 public sandboxes, and they checked for C. diff, which you thought was probably contaminated by animal fecal material. 21 of the sandboxes of the 40 contained C. diff spores, and 8 were the pathogenic type. And so just one more thing to think about with your kids out there. Then this author guy, it's probably like he wears Birkenstocks or something. He wrote, first of all, C. diff does not usually sicken children younger than 2 years. We have to learn to live with these agents. If our children live in a highly clean environment, their immune system will not develop in the correct way. All right, so if you do have a sandbox, you should cover it and obviously keep your dogs out of it. And what would be this meeting without an article on C. diff? And this just came out recently. What it talks about is while the increased incidence of C. diff has continued to increase, it's particularly increased amount of what's called multiple recurrent C. diff infections. So people coming in over and over again, which we see all the time in the hospital with the C. diff relapses. So this was a study. They looked at 40 million medical records on this computer over a 12-year period. They defined multiple recurrent C. diff as when somebody had at least 3 episodes. And they found 45,000 patients with C. diff. Almost 1,700 of them had this multiple recurrent C. diff infections. So over this 12-year period, the incidence of C. diff increased by 42% during this time period. But the incidence of this multiple recurrent C. diff increased by almost 5 times that, up to almost 190%. So C. diff is continuing to increase, but the people getting this relapse, and probably it's related to this NAP1 strain we've talked about. It's a much nastier form of C. diff. It has overwhelming amount of toxin reduction. It's much more likely to the spores to regenerate. And so it's just, again, one more example of that C. diff is becoming a much nastier bacteria and killing more people. The risk factors for this recurrent C. diff, as you can imagine, with the typical older people on repeated antibiotics, again, this PPI use, steroids in skilled facilities. And so, definitely one of the things we're looking at some of our hospitals is to get people off PPIs. Even why are people put in PPI into the hospital and they end up staying on forever. They don't know why they're on it. If they're coming in the hospital, getting them off them, because you need the acid to try to block the spore formation. And so those are things. And obviously, what we're seeing often in skilled facilities, people are getting antibiotics for asymptomatic bacteria. They're already colonizing, so they come in and they have these toxic episodes of C. diff. Again, so minimizing antibiotics, getting rid of PPIs are all very important things. And again, if you have these patients with these risk factors, be much more aggressive about treating them. I think that's it. You guys have any thoughts or what you guys are doing in your facilities? We'd like to hear from any input.
You can unmute yourself at the bottom left-hand corner of your screen, or *6 if you're on here.
So just to summarize, MRSA, nasty. A lot of it, patients could be coming in, and you may want to look at decolonizing them, particularly if they're going for seizures. Bladder infections, make sure that we just don't go crazy, don't do cultures, just treat them with Macroderma bacterium if there's symptoms. And even if the urine's negative, you do it, still treat it because it's almost certainly an E. coli bladder infection. Treat IV bacteremia with 2 weeks of IV to oral therapy. Keep your kid out of the sandbox.
The other thing is, if patients come into the ER with multiple episodes of MRSA abscesses, you then have to start looking at their family members, because you can have a family member or a couple of family members that are colonized. You decolonize this person, but as soon as they go back to the family, they get recolonized. So then you have to do the whole family.
It's like trichomonas or any of those things, chlamydia.
Just like that.
Well, the other thing is MRSA is a sexually transmitted disease in San Francisco a few years
Yeah, I
ago.
remember.
Yeah, so it is on the list. All right, so please call us. You have our cell phone numbers are on the line. If you, anything we can do. If you have questions, please contact me. You just text me and tell me about your patient, or I'll be happy to call you.
He likes
Actually, hi.
Yes.
Hi.
My name is Dr. Altamimi. I'm a primary care doctor from Nevada Health Center. And I want to ask about the urinary tract infection, recurrent urinary tract infection, and when do we start the preventive or the chronic suppression antibiotic for those people?
That's a tough one because you're going to just induce resistance to your standard antibiotics.
What's your definition of? I just make sure that your definition of recurrence is truly a recurrence of symptoms and not a positive UA or a positive urine culture. If they truly have recurrent symptoms, that can be difficult. And I honestly don't. There's not really any good guidance on when to start prophylactic therapy.
So I have a few patients that they come in for recurrent symptoms, including dysuria, frequency, hesitancy. Some of them, they had fever. I have almost 3 or 4 patients, and they have them almost like every 3 months. And one of the patients every month. She's diabetic. I understand diabetes can be part of it, and we are trying to control her diabetes. But she's at the level that her frequency, hesitancy, urgency it was out of control until I put her on antibiotic, and that helped her. She had multiple of urine culture which came back positive for E. coli.
Was it the same E. coli each time? Could you tell? Because sometimes they could have like a stone in their bladder or something else like that that's causing it. Don't follow up. If she has a bladder infection and symptoms go away, don't do follow-up cultures on her. But usually diabetics, we look for like stones or things like that, which could be a nidus infection. But never do, if somebody's symptoms go away, do not repeat the culture, okay? Never do that.
Have you worked her up for stones?
Say that again.
Have you worked her up for stones?
Have I culture her? What?
You do an ultrasound looking for.
Looking for stones and looking for bladder or kidney problems. Yeah, we've done that, and she doesn't have any stones, and there is no kidney issues. And I had 3 different patients like that. They are older patients. One of them, she has uncontrolled diabetes. I'm trying to control her diabetes. I assume that her diabetes can cause her hesitancy frequency. But the other 2 patients, they did not have diabetes. And I don't repeat their culture unless they come back with symptoms.
I mean, the other thing is sometimes older women get like a bladder prolapse and stuff like that, which they could have trouble emptying their bladder.
That is correct. We had a gynae lady here, which she saw two of those, and those patients did not have. One of them had actually total hysterectomy. The other one she didn't have any bladder prolapse or uterus prolapse.
And if you do, I encourage you to use caution if you do chronic prophylaxis and to shy away from macrobid for that reason. It's associated with a lot of very toxic long-term side effects when you use it for long-term therapy, especially in an elderly person.
Yeah.
Stuff.
The other thing is you can have them keep antibiotics at home as soon as their symptoms develop, have them take it for 3 days.
Yeah, and limit the duration of which you, that might be an option. If there's an inciting event that, she knows that it's a certain thing, usually she'll get a UTI afterwards, then you can potentially prophylax around that time. It's hard to say for sure.
Okay.
Thanks for the question.
Thank you for the question. That was very nice. Anything else?
That statement regarding children under 2 years old not getting sick by C. diff, is that because they're colonized by C. diff when they're born, or?
I don't know.
It's been a while since I've read on this, but something about they don't have I've read something about the receptors to induce a disease. They're just colonized, even if they're producing toxin, is from my understanding. But I think it is relatively controversial, but I don't think anybody has a 100% answer.
I thought that was the answer. I mean, unless there's new information that
I guess I just haven't seen it
newborns don't have
practice.
the receptor. If it's not going to bind to the lumen of the
But at what point do they develop those receptors, I guess?
I don't know. And that probably varies.
Huh. Yeah. Thank you.
Hey, Kia.
Thanks everybody for coming today.
Thank you, guys.
Thank you.
Alrighty.